Okay guys, now in this short video, I am quickly going to discuss today's INICET May 2025 question paper. Now this video will be a very crisp and very concise. Of course, I'll teach you the art of eliminating the options. So today's paper was sort of tricky, typical INICET style. So you cannot say that there were one-liners, but yes, each topic was asked in a proper depth, right? So we'll try to decode, and I'll also tell you how to eliminate the options one by one. Now let's first start with the question, which was, which of the following is not the treatment for amblyopia? Now amblyopia is stimulus deprivation, loss of vision. Now what are the causes of amblyopia? So there is congenital cataract. So any lesion or any disease which does not allow the light ray to fall on the retina properly, it will make the brain to suppress the growth and development of that eye whose retina is not being stimulated. So congenital cataract, there can be a mechanical cause, which is ptosis. There can be high refractive error. Mind you, there is a most common cause, which is anisometropia. Now anisometropia is difference in the refractive error of two eyes, but significant anisometropia is when the difference in refractive error of two eyes is more than or equal to 2.5 diopter. I hope it is well understood. Okay, now another is strabismus. Okay, what is the treatment? So if one eye has gone into amblyopia, you patch the other eye, the normal eye, the sound eye, so that the brain starts using the amblyopic eye and again restarts the growth and development of the eye which was earlier suppressed by the brain. Okay, now talking of the answers, the options which were there. So I told you that you will patch one eye, so of course this is done. Yes, so this option is clearly eliminated, not the option. Now video games. Now many students, they thought that okay, video game, this is very vague, so let's mark this. But always remember, the INICET people, they love to play with the minds of the students, right? So video game, there is a new therapy which is your Binocs therapy, BYNOCS, in which the red and blue glasses are given and the patient is asked to play video games. Yes, and will not be going into depth of the entire the SOPs, how you ask the patient at what distance the patient should sit and how many sessions are required. So that is very deep, going into very deep, so we'll restrict ourselves. So the patient will play video games. So because there are red and blue colored glasses, so there is some sort of stereopsis which will also be developed, and those video games will actually correct amblyopia because of differential stimulation of both the eyes. And that therapy is Binocs. It is relatively a new therapy, and mind you, I always say in my classes that practically you can treat amblyopia by 12 years of age, 12 to 13 years of age, while theoretically 7 years of age. But with Binocs therapy, the company claims, which initiated this Binocs therapy, which did all R&D, that you can treat any aged patient with Binocs, right? Okay, so this is of course used as a treatment, so not the option. Now there are two options which are left. Now you will say, sir, you just mentioned strabismus. Okay, so strabismus can cause amblyopia and refractive error can cause amblyopia. Now the option is refractive error correction. Of course, if the patient is having refractive amblyopia, so first you will correct the refractive error, then you will go on for patching. Yes, so that is the correct option. So refractive error correction is the part of amblyopia treatment eventually. Okay, now we are left with strabismus surgery. You will say, sir, Strabismus you have mentioned, so won't we correct strabismus? Mind you, strabismus is a very broad term. What if the patient is having accommodative esotropia? If the patient is having accommodative esotropia, of course accommodative esotropia can be refractive, in which there is hypermetropia, non-refractive, in which there is high AC by A ratio, mixed when there is hypermetropia as well as high AC by A ratio. Do you go on for simple refractive surgery? No, you don't. What is the treatment of accommodative esotropia? You correct hypermetropia, you do refraction. Yes, and again, if we are talking of strabismus, what if there is accommodative esotropia? You are going to go on for glasses na, so that is the best option to be ruled out here. Yes, okay. Only surgery is not the option available for the treatment. There are multiple other options, right? So out of these four, all right. Now, a farmer with cataract surgery presented after 2 weeks with decreased vision. So the surgery was uneventful. On examination, there were anterior chamber cells and flare. So flare is due to proteins in the anterior chamber. Anterior chamber cells, they both point toward uveitis. Yes, anterior uveitis and hazy vitreous. Hazy vitreous goes in favor of vitreous exudates. So collectively, vitreous exudates, cells in the anterior chamber, proteins in the anterior chamber, we are talking of endophthalmitis. We are talking of endophthalmitis. Okay, but let's eliminate the option one by one. What is TAS, toxic anterior segment syndrome? While doing cataract surgery, if we leave cortex inside the anterior chamber, the lens protein is a sequestered antigen which has never been exposed to the body of the patient. So the body will start producing antibodies against the lens protein, and there will be inflammation in the anterior chamber. You will call it as toxic anterior segment syndrome. But as the name suggests, we are talking only of anterior segment, right? So, but here vitreous is also involved, so it is clear cut eliminated. Now, sympathetic ophthalmitis. So when there is penetrating trauma, there is damage to the ciliary body. The ciliary body pigment, which is retina S antigen, it is released into the blood. So it will incite an inflammatory response, and there will be inflammation of the traumatic eye and also the inflammation of the normal eye, because the antibodies will make its way through the blood uveal barrier of the other eye as well. So sympathetic ophthalmitis is bilateral non-suppurative granulomatous pan-uveitis. Of course, you are going to see vitreous exudates can be there. There can be cells in the anterior chamber, proteins in the anterior chamber, but it will be bilateral condition. Is there any mention of bilateral condition? Not at all. Yes, so this is also eliminated. And sympathetic ophthalmitis can follow cataract surgery if there is inadvertent injury to uvea during cataract surgery. One, they have not mentioned any event, and second, it is not bilateral, eliminated. Third, we know it is now endophthalmitis. Now, if we talk about endophthalmitis, we have early post-op endophthalmitis, which happens to be within 6 weeks of cataract surgery. Then late post-op endophthalmitis, which happens to be more than 6 weeks of surgery. And if we are talking of less than 6 weeks of surgery, it is your staph epidermidis. If that is not in the option, it is your staph aureus, while late is Propionibacterium acnes. Now it is clearly mentioned that after 2 weeks, so you will go on for endophthalmitis with staph aureus. Got it? Chalo. Third question, advanced stages of diabetes mellitus. What is the cause of retinal detachment? So in diabetes, you know that there is one which is non-proliferative diabetic retinopathy, and another is proliferative diabetic retinopathy. Proliferative diabetic retinopathy means there is neovascularization. Now, which retinal detachment is associated with neovascularization? It is clear cut, which is tractional retinal detachment. But if we talk about rhegmatogenous retinal detachment, it is associated with high myopia, aphakia, and trauma, which is not mentioned in the question. Eliminated. No detachment. No, I don't know what was the fourth option. Some students said that it was no detachment, but they have clearly mentioned cause of retinal detachment. So let's take it as if we don't have the fourth option. Exudative. What are the causes of exudative RD? Central serous retinopathy, choroidal melanoma, malignant hypertension, gestational hypertension. So these are the features. VKH syndrome, these are the causative factors of exudative retinopathy. Mind you, in rhegmatogenous retinal detachment, there is liquefaction of the vitreous which enters into the holes or cracks created on the retina, and it goes in between neurosensory layer and retinal pigment epithelium, cause its detachment. Number one. Second, in exudative retinal detachment, there is fluid which is coming from posteriorly and it is going to enter between the neurosensory layer, retinal pigment epithelium. Third, tractional is there is formation of neovascularization on the inner surface of the retina, which will cause its pulling towards the center, and hence there will be concave configuration of the retina. Okay, and this will be tractional retinal detachment due to neovascular membrane on the inner surface of the retina. So the answer is pretty straightforward. Now the medium used for storage of cornea and the suture which are applied is, now moist chamber is, you take the eyeballs of the patient, so the one who has pledged his eyes for donation, eyeballs, and keep it in a moist chamber, airtight chamber, on which the wet gauze peas are placed at the bottom, and it can preserve the cornea for nearly 24 to 72 hours, 3 days. And you take out the eyeball, you cut it, procure the cornea. If you have watched my lectures, so I usually show you how I was dissecting the eyeball which I had received through moist chamber technique for corneal transplantation. Now next is McCartney-Kaufman medium. Here you can preserve the eye for nearly 4 to 5 days. MK medium. And of course, if you want to transplant the cornea, you apply sutures which are nylon 10O sutures. But let's discuss other two options. So Optisol, in Optisol you can keep the cornea for approximately 14 days. Again, only the cornea, but if we talk about only the eyes, that is your moist chamber. And sutures, Vicryl, no, not at all. Polyethylene glycol is the component which is used for dry eyes. It is a lubricant, and of course nylon is the suture which we use, but polyethylene glycol is not used for preservation. So the answer is McCartney-Kaufman medium. Is it good? Samajh mein aaya? All right, so the answer is B. Now what is the diagnosis? So there were two schools of thought. So one student shared this image with me, another student shared this image with me, right? And on consensus I am being told that this was the image which was asked. So first I am going to tell you one important thing. So once you will see this, the things are going to get pretty clear. So let's check this out. So frontal lobe anatomically is one, but functionally it is divided into right part and left part. So there are fibers which are coming from the right side of the frontal lobe. They are going towards left PPRF. PPRF is parapontine reticular formation which supplies ipsilateral lateral rectus and contralateral medial rectus. But when it supplies contralateral medial rectus, it has to pass through medial longitudinal fasciculus. तो इसका मतलब ये हुआ, the left PPRF will receive the supply from right frontal lobe, and left PPRF will stimulate right medial rectus and left lateral rectus. Okay, now what if there is sphering of right medial longitudinal fasciculus? When you ask the patient to look onto the right side, so right eye will move right, the left eye will also move right, so there will be dextroversion which is shown here. So this is the right eye, this is the left eye. But when you will ask the patient to look onto the left side, because of the damage to medial longitudinal fasciculus, the left eye will not adduct, but the right eye will abduct. So there will be one eye which will be facing outside and one eye which will be facing forward. So there will be a situation of diplopia. To undo this diplopia, so there is a voluntary action of me trying to move my eyes on the left side, but since there is damage to the right medial longitudinal fasciculus, the right eye will not go left, but left eye will go left. So there will be diplopia. To undo this diplopia, there will be involuntary action to bring the left eye towards the center, but voluntarily I am trying to take it outside, but involuntarily towards the center, outside center, outside center, outside center, such that there is ipsilateral adduction defect with contralateral horizontal nystagmus. Have you understood? So probably there is medial longitudinal fasciculus defect on the right side. So this is known as, my dear friends, internuclear ophthalmoplegia. Let's decode other options. Had there been third nerve palsy, agar third nerve ki palsy hoti, so what would have been the case? So the position of this eye would have been outside, because third nerve palsy, the condition is down and out gaze of the eye in normal baseline position. So that is eliminated, third nerve palsy. Horizontal gaze palsy, had there been horizontal gaze palsy, so of course there would not be like the eyes moving there and there is horizontal nystagmus. There is no chance of horizontal nystagmus. This horizontal gaze palsy means either there is problem in the abduction or there is problem in the adduction. If there is problem in the abduction, let's say sixth nerve palsy, if we take it as sixth nerve palsy, what will be the normal position of the eyeball? It will be isotropic, but it is in the center, isn't it? So this option is also eliminated. If there is myasthenia gravis, there will be involvement of both the eyes. Yes, so this is also eliminated. And why there will be nystagmus? So the nystagmus is not explained by any other option but internuclear ophthalmoplegia. Okay, all right. Now coming over to definition of blindness. So there are two definitions. One is as per NPCB. Now the NPCB is VI, National Program for Control of Blindness and Visual Impairment. Another is WHO. So WHO is when the visual acuity is less than 3/60 in better eye with best correction. So this is one definition. ठीक है जी. While NPCB, अब देखिए यहाँ पे थोड़ा ना वर्ड प्ले है तो उसको थोड़ा डिकोड करने की कोशिश करेंगे. जो NPCB है, NPCB ये बोलता है अर्लियर NPCB was 6/60. ठीक है. Now the definition which is given is as per NPCB, the line of definition is changed as per WHO. वो एक लाइन लिखते हैं as per WHO. PIB का ये एक notification है as per WHO that the visual acuity is less than 3/60. Okay, and with presenting visual acuity. अब आप बोलोगे सर एक तो साथ में वो लिख रहे हैं इन लाइन विद WHO, बट WHO तो बोल रहा है कि बेस्ट करेक्शन है, बट ये बोल रहे हैं विद प्रेजेंटिंग. अब बिकॉज दे हैव स्पेसिफिकली मेंशन्ड विद प्रेजेंटिंग विजुअल एक्विटी, तो हम विद प्रेजेंटिंग विजुअल एक्विटी को ही लेंगे. बट द क्वेश्चन वाज डेफिनेशन ऑफ ब्लाइंडनेस. If there was WHO, so the answer would be your after correction in better eye, visual acuity less than 3/60 after correction in better eye, right? But अगर NPCB की बात करें तो यहाँ पे confusion है. एक लाइन में वो लिखते हैं कि as per WHO, in line with WHO. If they have to take it in line with WHO, so it should be the same, which means best possible correction, right? But after writing, after completing the definition, they say presenting visual acuity. क्या बोल रहे हैं वो? presenting visual acuity. अगर presenting visual acuity बोल रहे हैं तो it should be NPCB if you will take it as presenting visual acuity. I hope it is now clear, है ना? So it depends what was specifically asked, WHO or NPCB. Okay. Now acute hemorrhagic conjunctivitis is caused by, now first and foremost if we talk about viral conjunctivitis, so we have got epidemic keratoconjunctivitis, the most common organism is adenovirus. कौन सा है? Adenovirus. But if we talk about acute hemorrhagic conjunctivitis, boys and girls, there is pico-RNA virus. Pico-RNA is a broader group under which we have got enterovirus 70 and we have got Coxsackie A24. ठीक है जी, Coxsackie A24, acute hemorrhagic, right? Now if we go back to the option, so one was Coxsackie A24, another was enterovirus 70. Enterovirus 70, mind you, is the most common virus which is causing acute hemorrhagic conjunctivitis. Now poliovirus eliminated, Coxsackie A is associated, not B. So now B and C should be the option of choice. So first, which includes B and C. Done? Okay, now best test to visualize all layers in the retina. So I always tell about these investigations in my classes. So perimetry is for visual field testing. Visual field means there is a perimeter, you give remote to the patient. Whenever there is flash of light, the patient has to press the remote and there is auto generation of the visual field in which you will know which areas the patient is not able to see. So that is something functional. Yes, not the layer, not the anatomical or histopathological. Yes, eliminated. B scan is the ultrasound of eye. In simple terms, it is the ultrasound of eye. Okay, all right. Here you can check about lens, whether it is subluxated, dislocated, the thickness of lens. You can also check about the vitreous humor, retina, whether it is detached or attached, whether there are choroidals which are present, whether there is optic nerve sphering is there, any foreign body which has entered in the eye, you are looking for intraocular foreign body, any tumor, retinoblastoma, that is your B scan. FFA illuminates the vascular path or vascular channel of the retina. So this is to assess the angiography. As the name suggests, fundus fluorescein angiography. You inject fluorescein dye and after 11 seconds the dye appears in the retinal circulation. You take multiple images with the red free light and the entire circuit is illuminated. What is OCT? If you remember, I have shown you the real patient OCT. So there is a dip and I always tell something that this dip is actually your foveal dip, and there are two hyper reflective layers which are red in color. One is your nerve fiber layer, another is your retinal pigment epithelium. If you could recall, I had shown you a case of central serous retinopathy in which there was fluid which was being collected between the neurosensory layer, retinal pigment epithelium, right? And there was detachment of the retina, and I was telling you that these are the 10 layers of the retina. So the answer is OCT, which is optic coherence tomography. Okay, all right. Now coming on to the last question. In optic neuritis, which is true? Very, very important. Now, first is 70% of the patients present with optic neuritis. See, optic neuritis may be seen in 70% overall of the multiple sclerosis patients who have their indication on MRI. So in which you will see the lesions on MRI. So 70% of those patients you will see. But how many patients of multiple sclerosis actually present to you with optic neuritis? It is not 70, boys and girls, it is 30%. So this is incorrect option. Oral steroid is preferred initially. No, you give IV methylprednisolone. I repeat, you give IV methylprednisolone 1 gram stat dose, which is followed by 1 milligram per kg body weight for 11 days. And it is seen in the research papers that if you will start oral dose instead of IV, there will be flaring up of optic neuritis. So this is also eliminated. Now next is optic nerve normal with no disc edema. So no option is there. Optic nerve normal, of course. So see, if we talk about optic neuritis is a broader term. So there are three things. One is retrobulbar neuritis, another is papillitis, and third is your neuroretinitis. Okay. Now retrobulbar neuritis is when there is inflammation of the retrobulbar part of the optic nerve. Okay, so which lies inside the orbit, intraorbital. So when you do fundus examination, you will see that the optic nerve head is normal. So the patient will typically come to you and say, डॉक्टर साहब मुझे कुछ भी नहीं दिख रहा. आप पेशेंट को बिठाओगे, फंडस एग्जामिनेशन करोगे, आप बोलोगे पेशेंट मुझे भी कुछ नहीं दिख रहा. तो patient is actually not able to see anything, but the doctor is not able to see anything abnormal in case of retrobulbar neuritis. While in papillitis, there is inflammation of the intraocular portion of the optic nerve. There will be disc edema, disc swelling will be there. Even neuroretinitis is inflammation of neuroretinal rim, and there will be disc edema, means the margin will be non-defined. But here they have used a broader term, optic nerve normal with no disc edema. So probably they are talking of optic nerve head, and of course this option is correct. Yes, if we take it as retrobulbar neuritis. And what about this? Color, vision and contrast are proportionally affected to visual impairment. Now guys, see, it is clearly mentioned in your Kansky 10th edition that of course there will be loss of vision, there will be loss of contrast sensitivity and also the color vision, but the recovery of contrast sensitivity or color may be earlier than loss of vision. Yes, so based on this, the option which I will pick is C. But if you will say, sir, of course if the recovery is early, is there any mention that the loss of all these factors will be proportional? I have gone through Kansky's 10th edition and there is no mention of this. And also based on the options, so I believe that there were not a combination of C and D options at all. So of course A is there, but A is clearly eliminated, so this option is already out. But A again, this is already out. B and D, B again eliminated, so this option is also out. So we are left with the C option. Yes. So all right guys, so this was my discussion of INICET May 2025 today's paper. I hope you got a decent score, and let me tell you, out of these 9 questions, 5 questions came from my recent OLR series which I had discussed 2 days back on my YouTube channel. It was just 90-minute session and the hit rate was, there were 5 questions which came in the exam, है ना? And if you have any issues, any queries, any doubts, you can always reach out to me on my WhatsApp number. I'll be very happy to respond to you. And yes, I wish you all the best for your upcoming results and also for your NEET PG.